This video series will cover opioid overdose recognition, the physiology of opioid use, and how to treat an opioid overdose. If you're treating an opioid overdose in a professional responder capacity, ensure you review and follow your agency's policy, protocol, and standard practices. The steps outlined in this video coincide with the most current overdose management guidelines by using medical best practices and acting in good faith. The opioid overdose management that we cover in this video are those found outside of a professional medical treatment environment and will focus on the abuse of illicit opioids that are commonly found in recreational overdoses. In controlled medical professional settings, opioids are classed as analgesic drugs used in the management of pain, while iatrogenic overdoses, meaning accidentally induced during professional medical care, are rare. They are possible and are managed using a similar treatment as discussed here. It is also important to understand that these treatments are to specifically manage overdoses from opioids only. The main treatment for an opioid overdose is artificial ventilation and the administration of the drug naloxone. If opioids are not the cause of the overdose and it is due to a different type of drug, naloxone treatment will not be effective. Opioid overdoses have increased fivefold in the last 20 years due to the ease of access to high-strength opioids by the public. Every 12 minutes, someone overdoses on an opioid in North America. This translates into a higher likelihood of coming across an overdose casualty, whether you are a member of an emergency services, a family member, or a friend, or a completely non-related witness. Opioids are a substance that occur both endogenous and exogenous. Endogenous meaning produced inside the body, and exogenous meaning produced outside and introduced into the body. The body's main endogenous opioid neuropeptides are endorphins. This term is created by combining endogenous, which means proceeding from within, and morphine from Morpheus, who is the Greek god of dreams, into endorphin or endorphin. These are the body's natural painkillers and are produced and stored in the pituitary gland. When pain is experienced through nervous system signaling to the brain, they are released from the pituitary gland into circulation, where they will then bind to mu opioid receptors in the brain and spinal cord, among other minor locations. Once bound to these receptors, they block the pain signal and cause an increase in dopamine production, which is associated with the feeling of pleasure. Exogenous opioids are produced externally and introduced into the body. These include medical and recreational drugs and can be produced from plants or synthetically in a lab. Organic opioids are primarily derived from the poppy plant as opium and used to manufacture both heroin and morphine. Synthetic opioids produced in a lab include fentanyl, remifentanil, and carfentanil as a few examples. Both organic and synthetic drugs cause the same effects, with each drug having a different effective dose, onset time, and half-life. In a medical context, these are typically used for both acute and chronic pain management. In a recreational context, they are used to get high and are illegal in all jurisdictions in North America. In surgical and emergency medical settings, opioids are typically administered via intravenous access, though they can be delivered by intramuscular injection and other routes. Prescription pain management is most likely in pill form, though sometimes is delivered via a transdermal patch. In the illegal drug context, it is typically sold as a powder, though can also be abuse of prescription medications, be them their own, their family, or friends, stolen or purchased through black market pill sales. These drugs enter the body in different forms, including swallowing, intravenous injection, or inhaling by smoking them. Opioid-based prescription pills that are normally involved in an overdose are usually limited to a few very common pills. The main one being oxycodone, a pill that is widely prescribed for post-surgery and chronic pain management. Other types of commonly abused pills are morphine, hydrocodone, hydromorphone, and oxymorphone. When it comes to illegal street drugs, only 2 opioids are used with frequency and are the cause of the majority of overdoses. These are heroin and fentanyl. Remifentanil is rarely used recreationally due to its short half-life, and carfentanil, on the other hand, does show up in the illegal drug trade, and because of its potency, will almost always result in an overdose. In the context of overdose, all the opioids do the same thing and can be used interchangeably in examples. However, as previously mentioned, their effectiveness is relative to the dose and half-life. An equianalgesic chart shows the equivalent doses of analgesic drugs. Morphine is the prototype drug for opioid analgesics. A prototype drug is a representative of the drug class and was usually the first one that was created. For this reason, morphine is given a strength rating of 1 at 10 milligrams taken orally, to which all other opioids will be compared. Oral morphine is only 25% bioavailable. Given IV or IM, morphine becomes 100% bioavailable, therefore it has a strength rating of 3, with an equivalent dose of 3.33 milligrams. Oral oxycodone has a strength rating of 1.5, with an equivalent dose of 6.67 milligrams. Heroin, which is a common recreational drug, is called diamorphine in medicine. Taken IV or IM, it has a strength rating of 4 to 5, with an equivalent dose of 2 to 2.5 milligrams, so it is slightly stronger than morphine. Fentanyl, taken IV or IM with 100% bioavailability, has a strength of 100 times that of oral morphine with an equivalent dose of 100 micrograms. The bioavailability and thus equivalent dose varies depending on the delivery, with 33% by sublingual, 92% transdermal patch, 89% intranasal, and 50% buccal. Carfentanil is used in veterinary medicine for anesthesia of large animals such as elephants. Its strength rating is 10,000 with an equivalent dose of 1 microgram. This is why any street drug laced with carfentanil will almost always result in an overdose. On 23 October 2002, 40 to 50 armed Chechens took 850 hostages in a Moscow theater. The Russian military released a gas to end the siege, which in 2012 British researchers determined was most likely a mixture of aerosolized remifentanil and carfentanil. At least 170 people died in the event, and it is determined that 125 of them were from respiratory failure. Rescuers were not made aware of the agent used. Had they been, they could have better prepared and prevented many deaths with the use of mechanical ventilation and reversal drugs. As previously mentioned, once an opioid enters the bloodstream, it is transported and binds to mu-opioid receptors. These cells are located in the brain and spinal cord and specialize in pain modulation. Once attached, they send signals through the nervous system, creating the opioid effect, which blocks pain, slows breathing, and has a general calming and antidepressing effect. Opioids also slow bowel motility and suppress coughing. Naturally, the body cannot produce enough endorphins to stop severe or chronic pain, nor can it produce enough to cause an overdose. When exogenous opioids are introduced into the body, they mirror these same natural effects, but to a much stronger degree. When used properly, these opioids are enough to stop severe or chronic pain. They do, however, have addictive properties. It is when the opioids are abused that the person's tolerance threshold can be surpassed and an overdose occurs. As we mentioned, opioids affect the part of the brain that controls breathing. If opioid levels become too high, the increased opioid effect will cause the person's breathing to slow down to inadequate levels or completely stop. This produces a lack of oxygen uptake and retention of carbon dioxide in the blood. If uncorrected, this will eventually cause death. The casualty will continue to deteriorate until one of 3 things happens. At borderline threshold levels, the person may have an altered level of consciousness and have a breathing rate drop. But if the dosage was within the individual's tolerance, their body may be able to metabolize it in time to increase their respiratory rate and come out of the opioid effect without intervention or detrimental effect. This is the typical unreported drug user's trip or high, and is a high risk to life every time it is attempted. The second potential situation is where too much opioid is consumed. Their breathing rate continues to slow down as the opioid effect increases until their breathing fully stops. Without the vital gas exchange during breathing, their condition will continue to deteriorate until death occurs. The foundational reason a person will die from an opioid overdose is the lack of oxygen due to the body's depressed respiratory drive. Further study into the pathophysiology can be explored in the Understanding Trauma, Respiratory and Circulatory Anatomy, Physiology, and Pathophysiology video series. Fortunately, this is rarely an instantaneous outcome and can take minutes to hours to develop. It is very important to understand that an overdose can be treated without any reversal agents. Artificial respirations can be performed, theoretically, until enough opioid is metabolized so that the casualty begins to breathe on their own. There need not be reliance of a reversal agent to save the victim's life. The drug naloxone, often referred to by its brand name Narcan, is a competitive opioid receptor antagonist. What that means is that once introduced into the body, it will bind to the mu opioid receptors that the opioids typically would bind to and prevent the opioids from attaching. With the opioids unable to bind to the receptors due to the naloxone's blocking action, it speeds their metabolization and excretion from the body. Naloxone does not cause the opioid effect and has virtually no side effects, so it does not cause the respiratory depression that the opioids do. Thus, as it replaces the opioids on the receptors, the casualty will start to breathe again on their own. Naloxone reverses the entire opioid effect. So, not only does it reverse the respiratory depression, but also the euphoric feeling. In certain cases, opioid-dependent individuals will rapidly exit their opioid high and can become restless, nauseous, agitated, aggressive, and potentially violent. They may also vomit. To mitigate this, smaller doses may be given over a longer period of time, particularly for known and suspected chronic abusers, all the while supporting respiratory efforts is one strategy to consider. This concludes the Opioid Overdose Management Part 1 video. In the next video, we will discuss treatment of the opioid overdose casualty. Thank you for watching.